bulk data from over 450 patients for both trials, we looked at baseline data compared to week 14, which is the standard post-induction time point that we would have repeated that endoscopy, looked for that classic phenotypic change in response status, and use that to determine if a patient was responding or not. There's two things I'll call to your attention. One is when you look at the baseline data at week 0, you really don't see much in terms of enrichment of molecular signatures or pathways that are associated with the trajectory differences. But when you get out to week 14, that's when you start to see the emergence of mechanisms of treatment resistance or pathway enrichments that are specific for one drug versus the other. And because this was a head-to-head trial, we have the ability to account for any unmeasurable confounders because they were randomized at baseline. And the specific one that we saw that was most unique was this angiogenesis hallmark pathway. And as we started looking at the post-induction molecular signature there, what we realized was that that post-induction molecular signature was really a signature of vascular inflammation. So essentially what we found was when we resolve these patient trajectories using PRO-based assessments, we can find a gradient of enrichment for a very specific molecular pathway that emerges post-induction after exposure to the therapy, is incrementally higher across the 4 gradients, and is specific for vascular inflammation with some leading edge genes that help us identify how we want to hone in on what the potential molecular source of this is, how we want to think about this. This pathomorphosis concept is not novel. It's something that's been done in a lot of other spaces, particularly oncology, but now we have the opportunity to start to resolve that in the inflammatory space and the non-oncology space for looking at signatures. So we built a molecular signature sort of module that we found from this post-induction process. We validated in the second Gemini data set that it was associated with non-response to vedolizumab specifically. And when you take that post-induction signature and look at it now again at baseline, you can actually see that when we go now back to both the vedolizumab and the adalimumab data, but also other clinical trials for infliximab, another anti-TNF agent, and ustekinumab, an anti-IL-12/23 therapy, we can take that vascular inflammation gene signature, look at baseline molecular data, and you see that there's only an association with vedolizumab, not with any of the other therapies. So now we have a modified gene signature that was identified post-exposure to therapy, associated with non-responsive therapy, associated with a gradient of non-response, that we can then take to the baseline data and reevaluate and understand its association with non-response and that it's specific for vedolizumab. We had O-link data from the trial, and so what we then wanted to do is take the entirety of the gene signature, which you're seeing here, and look at which of the specific genes here were the most dominant source of that signature and that association. And on the left here, you're seeing the sort of molecular data and then also the proteomic data over here. And you can see that SPP1 on both the bulk RNA sequencing and the peripheral blood O-link data was the only one that was consistently associated with non-response for vedolizumab specifically. And so now we started whittling this down into a specific and unique biomarker that may help us identify patients who will specifically not respond to vedolizumab relative to other anti-cytokine therapies. And so what we did is we were able to access the serum that was banked from this clinical trial, and we went back and did ELISA for SPP1 specifically. So on the left here is the O-link data, and on the right is the ELISA data. As I mentioned, this was a head-to-head clinical trial, so you would have expected that unmeasurable confounders like a biomarker should be evenly distributed between both arms, and they were. This is the distribution curve for both adalimumab and vedolizumab showing overlap. But then what we saw was that in the vedolizumab treated group specifically, you had higher baseline levels of SPP1, and when you looked at the baseline expression of SPP1 corrected for prior anti-TNF exposure, steroid exposure, and smoking status, which is known to influence SPP1 expression, you were 50% less likely to achieve clinical remission at 1 year if you had elevated SPP1 levels if you were being treated with vedolizumab, but there was no association for outcomes with adalimumab. Then when we go over and do ELISA, you see again a similar baseline distribution between both arms in this randomized trial, and again, higher levels for the non-responders at baseline, and an odds ratio of 0.66 that was significant after adjustment, showing that this baseline biomarker of SPP1 was specifically associated with non-response to vedolizumab, with no association for non-response to adalimumab. So now we have a specific biomarker and an opportunity to start to think about a molecular source for that mechanism of resistance.